gentlemen. How you doing?
Hey.
I missed breakfast.
Who's the cowboy? Good.
Where's that video?
The video of this.
Charles.
We're going to be illustrating some stuff showing how to use the medication. So you probably hear better coming up front, but for sure you'll see better because some of it's pretty small and you'll want to know how to administer this medication. So I think the closer to the front, the better off you may be.
Do we need the microphone? Does this work better?
Yeah. I'm going to welcome you to this seminar. I'm glad that you came. This is a very important subject. This is Charles and Mark. Mark and Charles, being over this way you look. And they're the ones that we put in the seminar on today and answering all of our questions. So I guess one of you guys is going to go first.
Yeah, I can kick it off.
Let me know. Here, let me give you this microphone.
Sure.
Drop that.
Worst year we ever had.
Check. Y'all hear me? Now we can get you to understand my Cajun accent. We'll be doing all right. So Mark and I started this, came together with some folks in 2013 in Austin and started talking about the opioid overdose epidemic. At that time we were really seeing more of it on the East Coast, so we were really trying to get folks together to try to get ahead of this, right, for Texas. It's here, okay? Opioid overdose is the leading cause of unintentional deaths in this country. I never thought I'd be standing here saying that. 2015 alone, it killed more people than the entire Vietnam War. CDC has said if we keep going at the rate we're going, by 2020 it will be killing 100,000 people a year. Okay? This epidemic is being fueled by prescription drugs. We're definitely seeing an uptick as a result of some of the responses to this. Folks are getting cut off their prescription medications for whatever reason, and they're going to the street for their medications. We're seeing a huge rise in hepatitis C as a result of this epidemic, because research will show that folks that go to street medications, even if they start off snorting, they usually end up as injectors. And then that's where they increase the risk for HIV, Hep C, and other transmittable diseases. So today we're going to be talking about data in Texas, or lack of data. Mark and I actually do work on the Hill legislative session, trying to get laws passed. And legislators up there want to see numbers. They're up there looking at a clipboard saying, I don't see a problem. Mark will talk a little bit about it. We have 254 counties in the state of Texas, and I think 11 out of those 254 are recognized by CDC for having accurate data. Okay? So that's one of the issues. We're going to talk about how to recognize, respond, and evaluate in case of opioid overdose. Okay? We have medications here. There's 4 different forms of the medication. We'll be illustrating each one of them. We'll talk to you about how to access the medication, how you can pay for it. If you're an agency and you want to buy bulk, and all that good stuff. We've been fortunate enough, the State of Texas Health and Human Services Commission got a $27 million grant for the state of Texas called TTOR, Texas Targeted Opioid Response. Okay, out of that 27 million, 80% of that is going towards treatment, medication-assisted treatment. Okay, the other 20% is going for stuff like this. Okay, through T-Tour, we are able to give folks, like we call it a starter kit of medication. Okay, so that's how we was able to pick this medication we brought today. So Mark and I have been fortunate enough to go around the state of Texas doing this work, and he's actually done this work all over the world, all over the United States, saved more lives than anybody I've ever met as a result of his work. So at this time, I'm going to turn it over to Mark Kinsey.
Thanks, Charles. Good morning. Early on a Saturday morning. Need to thank the Creator for bringing me here safely this morning. There was a lot of Saturday mornings that this is not where I would have found myself, so I'm forever grateful for the opportunity to, do this work and the grace and mercy that's been given me. We'll go into a number of different things today, but what we're going to do this morning is that, unfortunately, the sound on this is not working, but there's a subtitle. This particular video is a video of a young lady in the Los Angeles area, and the Healthcare for the Homeless in Los Angeles was getting ready to do a mock demonstration of overdose and how to respond to it. And when they came out into the courtyard, there was an actual overdose going on. And so they recorded it. And so what you'll see, unfortunately you won't be able to hear it, but what you'll see, and there's subtitles, is that young lady that was affected by this. So Awado, and then we'll talk about it afterwards. Awado? So, any thoughts or feelings about that that affect anybody? So this young lady just celebrated a year clean and has gotten her children back into her life. That doesn't happen to people that are dead. And so there's a couple of things that happened in this video that are pretty crucial, and one of them is that this young lady was early on in her drug using career. and that she found herself in a position where there's obviously a negative event going on, and overdosed as a result. And because of the individuals at this particular community healthcare center, they had this medication that we're going to talk about today, and they were able to rescue her. This is a medication that, as soon as if you can go back a couple, I'll raise my hand when I want you to change the slides, if that's good. So, go ahead. Go to the mission. Next one. So, as Charles stated, in December of 2013, we came together as a result of what we potentially saw coming in the state of Texas. I'm from the East Coast. I've been dealing with this particular issue since 1996. In 1996, a young man out of Chicago, Illinois, by the name of Dan Big, started handing out and distributing naloxone, the life-saving benign medication, to individuals in the community that found themselves at highest risk for fatal overdoses. In 1997, I was able to perform my first rescue with the medication that Dan had supplied. And so I will tell you that when we talk about this medication and the simplicity of it, I still think that people think that the majority of rescues that happen as a result of this medication happen from folks like Marvin and EMS and paramedics and law enforcement and stuff, and I'm here to tell you that the vast majority, over 80% of all rescues that occur with this medication occur from either family members or peers. This is a medication that is so easy to use and administer and navigate around that everybody should have it in their medicine cabinet. If anybody, is there anybody in this room that knows somebody that knows someone who's overdosed? So, a couple people. Is there anybody in this room who knows somebody that knows someone that might be on pain medications for pain relief, chronic pain? And so, whenever we talk about this stuff, it's important to know, and I use my mother as an example, an 82-year-old woman who has a respiratory illness, COPD, and was prescribed Vicodin for a minor surgery that she was given. And the doctor never talked to her about the potential for dangerous outcomes. You have a respiratory illness, COPD, you give her a respiratory depressant, and the doctor never talks to you about the potential for an overdose. And so our older community, when we talk about this overdose epidemic, they think it doesn't affect them when in fact they're at great risk. We hear in nursing homes all the time that people are dying from natural causes, but when we actually look into it, they were over-medicated. And Charles will talk about some of that stuff in a little bit. But so when we came together, our goal was to reduce the fatalities associated with opioid use, whether that's recreational or prescribed, right? The one thing that I'm really clear on as a Christian is that we are supposed to take care of our brothers and sisters, right? This is a right to life issue for me. And that people, regardless of the decisions that they make, and maybe there's some bad decisions that are made, it shouldn't cost them their lives. It shouldn't cost them their lives. And so when we came together, we wanted to reduce the fatalities through education and this benign medication, naloxone. And so this workshop, we're going to look at what opioids are and explain the differences and similarities. We'll look at how they work on the brain. In simple terms, folks, we're going to look at the major risk factors, and interesting enough, I think that some of these risk factors are risk factors that a lot of us don't think about oftentimes. We're going to look, the important part, the meat and potatoes of this presentation will be given by Charles, and one of the things that he'll talk about is how to recognize the signs of an overdose, what it looks like. So, who in here has seen an overdose again? So, for those of us that have seen overdoses, I will tell you it's something that you'll never forget. You'll never, ever, ever forget it. And so, we'll look at how to respond to that when we come across someone with an overdose. And then we're going to look at the role that this medication, that the only thing it's good for is saving lives. Period. That's all it's good for. And then we'll talk about the laws and why the state of Texas has passed some laws that allow everybody in this congregation to be able to carry naloxone, you know, in the state. Every citizen in the state of Texas is eligible to carry this medication on them. You cannot overdose on this. You cannot overdose on naloxone. Done a lot of work with the federal government over the last 3 decades. And one of the things, you know, I worked early on, as did Charles, in the AIDS epidemic, and one of the things that you never heard the U.S. government say was, this is the epidemic of our generation. Well, I'm here to tell you, this is the epidemic of our generation. We, as a nation, have never seen anything like this. There are more drugs at a higher purity, at a lower cost, at greater accessibility than there is today. And regardless of your political affiliation, I don't care how high the wall is, right? You're not going to stop drugs from coming into this country, because we as Americans have a thirst for narcotics in this country like nowhere else in the world. We're 5% of the world's population. We're 5% of the world's population, and we consume over 80% of the world's hydrocodone. I mean, that speaks volumes, right? We don't like to feel in this country. We have a tendency to look for fast, quick, and in a hurry solutions to the issues that we face. And so this is the epidemic of our generation. Go ahead. So we're going to talk about heroin, morphine, codeine, excuse me, Demerol, Darvon, Dilaudid. And then we're going to talk about a lot about illicitly manufactured fentanyl, that drug, that street drug that you're now hearing more and more and more about, right? So let me tell you that fentanyl is not a new drug, okay? It's been out since the 60s. However, the way that these analogs are coming in right now and the potential for fatalities is different. Those of us from the East Coast have been dealing with fentanyl for decades. Fentanyl, it was in what we call China White, heroin, back in the early 80s. But, so we're going to talk about fentanyl. Fentanyl is 100 times more, what happened? Yeah. Fentanyl is about 100 times more powerful than morphine, about 60 times more powerful than heroin. The medication that Charles will talk about today only works on opioids. It doesn't work on sedatives like benzodiazepine or alcohol. It doesn't work on crystal methamphetamine or cocaine. However, this medication will work if there's opiates in combination with those drugs. So when we get to it, you'll see the importance of why we talk so much about illicitly manufactured fentanyl. Go ahead. So in many ways, opioids are the same, and in some ways they're different. They're the same in that they all come from the poppy or a derivative of a synthetic mimicking of the poppy, but they affect the brain in the same way in that they tell your body and your respiratory system to slow down, slow down, slow down, stop, which is basically what an overdose is. Morning, Bernie. I got to give my man a hug. Sorry, you're right. Bernie just drove down here from Santa Fe, well, not Santa Fe, Santa Fe, New Mexico. So he does a lot of work in New Mexico about this particular epidemic, and quite honestly, New Mexico is really the state that initiated much of what we see going on a national level. I remember Bernie and them talking about overdose prevention in the mid-90s, late 90s, when nobody else was talking about it. Giving it to inmates upon release now is something that's common, and following suit of what New Mexico is doing is going to be important, because let's face it, Texas is, you know, lined up right next to New Mexico to do some of the great work that they've been doing, so I'm grateful that he's here. But they cause overdoses in the same way as well. But they're different in their length of duration and their concentration of strength. And this is important because the medication that we're talking about, naloxone and Narcan, has a very short half-life. It lasts 30 to 90 minutes, folks. Many of these longer-acting opioids, when taken naloxone and Narcan, eventually will come and sit back on the opioid receptor. That will be important when we talk about evaluating what an overdose looks like. Go ahead. So again, methadone lasts 24 to 36 hours, heroin 6 to 8, oxycodone 3 to 5 hours. And we'd be remiss to not talk about Oxycontin in the face of what's going on, because Oxycontin has played a major role in what we've seen happening on a national level, right? I remember when Oxycontin first came out, they had 160 milligram Oxycontin, so very high dose of pain medications to give to somebody. Demerol, Darvon, Dilaudid, 2 to 4 hours, but fentanyl, illicitly manufactured fentanyl, only lasts 2 hours. Some of that's important to know, not only as a result of the overdose epidemic, but the climbing rates around hepatitis C and HIV. In a state like Texas, where people do not have access to clean injection equipment, right? That 7-cent piece of equipment, when you have to use it over and over and over again and share it with other people, dramatically increases the rates of hepatitis C. We have 400,000 people in the state of Texas right now with hepatitis C. 300,000 of them chronic. Vast majority don't know they have it. Vast majority don't know they have it. And the major route of transmission is through injection drug use, right? Law enforcement, to have clean injection program, safe syringe program, reduces law enforcement's exposure to needle sticks. It decreases drug use in the communities where syringe exchange programs are. There's a greater link to services for people that may not know services are provided. And yet our moral baseline says that we shouldn't do this because it encourages people to use, when in fact all the scientific evidence says to the contrary. But we pick and choose when we want to use scientific evidence. Go ahead. These are just pictures of some of the drugs, and Charles will actually show you the heroin and what we're seeing in the pictures of it, where it's coming from, and what it looks like. Go ahead. But the reason that people use opioids, untrue to the great philosopher Nancy Reagan, well-intentioned, I'm sure, but opioids in particular work to quell physical, mental, and spiritual pain, right? And we now live in a country where there is enormous rates of anxiety and physical pain and emotional pain and spiritual pain that's going on. And so opioids, quite honestly, are like the warmest blanket on the coldest night, folks. And so also understand that stigma and misinformation drives much of what we're going to talk about today. And I've heard some things today before the presentation about some misinformation that's out in our communities. And Bernie and I deal with this on a national level almost every day, where we're trying to dispel the misinformation that's out there. But also people use, because it's euphoric. There's no feeling like opioids. You don't have to like it. The fact of the matter is that people are using it until we get to the understanding of why that is the case. Then we're going to continue to see what's happening. So I want to ask this group a question real quick. And that is that I'm going to give you a definition of the word drug, okay? And I'm going to see who would identify with this. So the definition of the word drug, and correct me if you don't think it's correct. A drug is any substance in a small amount that produces change in the mind, body, or both. Does that work for folks? Yeah? So I would bet you my life savings, which isn't much, but I would bet you my life savings that under that definition, that everybody in this room would be considered a drug user. Under that definition. The reason that I bring it up is because the terms and the language that we use further drive people away from accessing services rather than bringing them into services. Addiction is a disease or an illness of separation. Separation from family, community, society, the Creator. The antidote for separation is connection, right? And yet, when we use language that further drives people away, like, you know, he's a drug user, he's a dope fiend, he's a junkie, he's all these negative connotations. It further drives people farther away. And so, we need to take a look at, those of us that are providers or even family members of people that might be struggling, how we think and talk about people that may be having this particular issue. We don't talk about this, any other illness like we do about drug use. None of them. And yet, when it comes to drug use, we just think that we can say and do and talk to people any way we want. Go ahead. Charles and I do a lot of work up at the legislature, and as Charles stated earlier, one of the things is that if you looked at the Centers for Disease Control mapping of fatal overdoses in the United States, you would say Texas does not have a problem. And what Texas has a real big problem with is data collection. Their ability to collect appropriate, accurate data so that these numbers can be counted from the Centers for Disease Control is lacking. Health and Human Services Commission is working on that. Who signs death certificates in the state of Texas? There's only 11 medical examiners in the state of Texas. JPs in 254 counties, JPs, untrained JPs, attorneys, sign death certificates. And the manner that they're signing these death certificates makes it look like we don't have a problem here, folks. So when we're working with lawmakers, we have to figure out how to bring light to the situation that's going on. And so what we bring in is some healthcare costs from national organizations that's what they do. And Texas is #2 for healthcare costs associated with opioid misuse. We also have third world nation numbers. The highest in the United States, the highest in North America for maternal mortality. It's the #1 killer for women post-delivery. Fatal overdoses. 86% increase over the last 18 months. The rest of the country's seen about a 26% increase. So we're #2 in the United States. We have third world nation numbers around maternal mortality. Go ahead. And we have 4 of the top 25 cities in the United States for prescription drug abuse. You cannot not have a problem. Be #2 for healthcare costs, have 4 of the top 25, and have the maternal mortality rates that we have and not have a problem. It doesn't line up. The other thing that I have to tell you folks that we have to oftentimes bring to legislators is that about 80% of all the illicit drugs coming into the United States right now are coming into Mexico. Okay? So some legislators know this, but some don't. But Texas borders Mexico. And so we're in the crosshairs, folks. And the reason that so much of the street medications are coming into Mexico is that they have figured out really sophisticated ways to transport it. And understand that drug distribution is about economics. It's about economics, folks. And so Charles will touch a little bit more about what that looks like as we move around the trends of this epidemic. Go ahead. We say 140 is probably close to 160 people are dying each day from fatal overdoses, and it's equivalent to a plane crash. Go ahead. A plane crash every 4 days. And in this country, we would close down every airport until we figured out what was going on. But because of who's dying and what it looks like, we haven't done that. Quite honestly, we would not be sitting in this church this morning had some things not started to line up. Go ahead. And this is part of the reason that we do this work, folks. So I know Bernie and Charles and I, we talk about this all the time. I get weekly phone calls from mothers. And if you've ever heard a mother on the other end of the phone screaming because they've lost their child, you'll never forget it. There's nothing like it. And so when we look at this epidemic and what it's doing, other than looking at this poster and noticing that it's a bunch of young white kids, they're all under 30 years old. They're all under 30 years old. This has to stop, folks. This has to stop. And so there are some really pretty simple public health initiatives that we can do to curb this. Go ahead. This is not new what's going on around the opioid overdose epidemic, folks. I was fortunate enough to be faculty at Yale University. In 1996, we started to study and look at fatal overdoses in some of the major Northeast cities in the United States. Baltimore, DC, Boston, Brooklyn, up and down the East Coast. And so we're looking at these numbers for medical examiners of 500 and 600 and 700 inner city residents dying each year from fatal overdoses, right? And this is 96. And also what happened in 1996 is a company by the name of Purdue produced a medication. Anybody know what Purdue made? Purdue Pharmaceuticals made OxyContin. 1996, OxyContin comes out, and it was marketed as a non-addictive pain medication, very good pain medication with time release on it, right? Doctors were incentivized to write prescriptions for this, right? And so what started to happen is that in communities that had not had great access to opioids, there now started to be a lot more access to opioids, right? Doctors were much more liberal around writing prescriptions. We're seeing the results of that, right? 1996, the American Medical Association named pain a vital sign, right? And so we started to see many, many, many more prescriptions going out into our communities. Younger and younger induction into opioid use. Where is it that most young people now are introduced to their first opioid? Where do they get it?
At a party?
Sometimes. Sometimes it's break a bone. At home in the medicine cabinet, in their parents' medicine cabinet, their friend's medicine cabinet, right? Oftentimes because we've had huge increases in prescribing practices, and there's, I'll give you an example. My niece, 18 years old, went in for a root canal. They wrote her 20 milligram Oxycontins. She's 18 years old. What she needed was ibuprofen, right? So the thing about opioids that are really interesting, in particular with young people oftentimes, if I'm a 14-year-old young lady whose body's changing and I'm breaking out with acne and I go to school and I'm getting bullied, and I go home and I go into my parents' medicine cabinet and I find this little pill that when I take it, it makes me go from suicidal to everything's going to be okay. It may not be the healthiest coping mechanism, but understand why people do it, right? Understand why people do it. And until we, as providers, as individuals, start to get to the bottom line of why people are doing this isn't going to change. Bernie and I talked, this is going to get worse, guys, before it gets better. It's going to get worse. And then I hear things in 12-step meetings that I go to like, well, so-and-so had to die so I could recover. Man, that stuff is just not healthy. It's just, first of all, it's not true, right? And to have that mindset, I would like for that individual that says a statement like that to tell that kid's mother that, right? And that even through legislators, Charles and I oftentimes will hear, well, this is a good way to thin the herd. Thin the herd? These are human beings. So in 96, we're looking at all this data, and by 1998, my hometown newspaper, the New York Times, comes out with a front page article that says, 4 suburban teenagers died from overdose. So the code for 4 suburban teenagers is young, affluent, white kids. That's what that means. And so we would not be sitting in this church in El Paso if young, affluent white kids didn't start dying. I'm not, for whatever reason this occurred, this is happening. But this is not new, folks. This has been happening in our country for decades. For decades. And because now it affects the bipartisan group of people, we're addressing it in a semi-appropriate manner. We do things like prescription drug monitoring programs, right? Not the worst thing in the world, pretty short-sighted, right? Where doctor shopping gets reduced dramatically, but it also reduces some really good health care for a lot of people that need pain medication. So, and by the way, when you eliminate someone's pain medication after they've been on it for 6 months, a year, 2 years, they're not going to just skip down Main Street real happy. All it does is produces a market, a black market for street medications. And that's what we're seeing. So, we see in 1998, Purdue Pharmaceutical hires us at the university to go to Appalachia, Washington County, Maine, because those are the two parts of the United States that started to see really high rates of fatalities. And what started to happen was very similar to rural communities in Texas, a lot of manual labor, a lot of stoop labor where people were given pain medications, right? And to be productive members of society, to be able to work and provide for their families. A lot of these jobs are seasonal. And so at 9 months, folks would be cut off their insurance. Well, they've been taking opioids for 9 months. Now they're cut off their insurance. They don't have access. What started to happen was the crime rate in those communities went up, and there became a market for street medications, like heroin, like fentanyl. And these were individuals that were opiate naive for the most part. And so we started to see the negative consequences of the liberalization of writing pain medication. Dr. Norman Zinberg, brilliant doctor, and if I would recommend anybody to get this book, it's called Drug, Set, Setting. And what Dr. Zinberg talked about, for those of us that are providers that work with individuals, who in here works with individuals that are drug users? So not many, but a few. What Dr. Zinberg figured out was providers, service providers are oftentimes the greatest barrier for people accessing help. Because we put in so many things in the way that people don't come in to get help. The other thing that service providers don't do is that they don't allow people that come in to access services to have an honest dialogue about the reason that they're in there. Their drug use. Because if they come clean about their drug use, the likelihood for them losing the services that they came in to get increased dramatically. I am someone that struggled with opiate addiction for over 20 years. Intravenous heroin use. And in those 20 years of going and accessing services periodically, no service provider ever asked me why I continued to shoot heroin. Because I would have told them. I would have been more than happy to tell them. But the way that we address addiction in this country is ludicrous. And whether you like it or not, there are some things that we need to change that are scientifically based. Like, what's the most appropriate treatment for opiate addiction? What is it, folks? Anybody know? Methadone. Methadone. And yet we think that that's a substitution, right? We think that methadone is an equivalent evil. We think that, here's the deal with methadone. Methadone is the most effective treatment for opiate addiction. How we do methadone in this country leaves a lot to be desired. Because addiction, through all the reports that we see, addiction is a disease, right? It's not a moral deficiency, folks. It's a disease, right? And yet, with this disease and the most appropriate treatment for it, we make people line up at 6 o'clock in the morning like cattle at a clinic to pee in a cup in order to get the medication to treat their illness. I beg of you to tell me one other illness that we do that with. But that's what we do around addiction. That's what we do to people. We shame them, we pigeonhole them, we disgrace them. And Dr. Zimberg talked about we need to eliminate that, break it down into the trilogy. And he talked about the drug, the pharmacological makeup of the substance that people ingest, right? Are they using similar drugs in combination? Like, are they using benzodiazepine, which is a depressant, right? Sedative, and opioids together? Because if they're using those together, the likelihood for overdoses increase. Are they using alcohol, benzos, and opioids together? Dramatically increases. That particular triangle is lethal. Or are they taking a stimulant with a depressant, thinking it's going to level them off, of which it doesn't? But talking to them about what they're using, how they're using, right? Are they using intravenously? Because I want to know, how do you do behavioral change if you don't know why people and how they're doing stuff? How do you do it? That's why we're in the situation we're in. We don't talk to people. We in particular don't talk to people in the struggle about the thing that they know the most about in their lives. Doesn't even make sense. Well, what Dr. Zimberg talked about was pharmacological makeup and then the set, right? And what that individual brings to a drug-using episode. Why is it that people continue to do what they're going to do? Because I'm here to tell you, drug users are not stupid. As a matter of fact, when that guy in North Korea pushes the button, you better find yourself somebody with a substance use disorder, get with them, because they're going to teach you how to survive. Smartest people I ever met, and I've worked at the highest level of academia. Drug users are the most resourceful, smartest people I ever met. Do some dumb stuff, don't get me wrong. Do some dumb stuff. But they ain't stupid. And if the drugs didn't work, they wouldn't be doing them, folks. Trust me. So find out why it is that people are using. Because in order to make behavioral change, you have to find out what the baseline underlying issues are, right? Are people using because they're in physical, mental, and spiritual pain? Are they using because they hear voices? Or are they using because they need to escape from the realities of the world? Because my interventions with people and the work that I do look very different when I'm working with someone that's using to stop hearing the voices as opposed to using to get high. My work with them looks very different. Go ahead.
When you talk about stigma in general, I mean, some of these folks, they have a mental health issue, diagnosed or undiagnosed,
Correct.
or just not really wanting to talk about it.
Right. Yeah, mental health and addiction often go hand in hand. You know, we don't talk about mental health in this country to begin with either. So, go ahead.
Hi, I have a question, concern, a comment, that just gets under my skin is, and I wrote it down because it bothered me so bad. The shaming part, that people in disease, because it is a disease, that we're shamed, and judgment is passed and that kind of thing. And it is a disease. But where my thought process leads me is the police department, or perhaps nursing, perhaps doctors, anyone in that type of position, how do they know how another addict or an alcoholic feels, that what they're going through, because they make their own rash decisions, own rash judgments from what they hear? How is it that, to get away from that shaming part, like what you were saying, that they're lining up for the methadone? They do it because they have to do it, but it's shameful, and it's, to that person it would be the same thing. But I would love to see in the future that there are more people within the law that go to a meeting, see what it's really like.
Yeah, I think there's a lot of things that we need to address for people to understand this, both addiction, mental health, and a number of things, right?
But how do we do it?
What?
How do we do it?
Well, there's a lot.
How do we get them to do it?
Excuse me?
How do we get them to participate in that?
Yeah, probably not going to do it this morning. Ah, God, we're never going to get through this. Go ahead, Mark.
Well, you have several law enforcement officers here today. And there are more concerns than you would believe.
Oh,
but we
that's
have
great.
an entire public to protect, not just one individual.
Absolutely.
So there are officers right now throughout this
Absolutely, that's very comforting.
But,
Thank you.
it's interesting. It's not law enforcement's job,
Right.
quite honestly.
Right.
It's not law enforcement's job, right? And we continue to blame, the job that I would least want in the United States right now would be law enforcement. Because you can't win on either side of this, right?
Correct.
And we'll talk a little bit more about that when we get through this. But nobody in my 20 plus years ever asked me why I kept using the way I was using. I would have told them. The traumatic situation with my oldest brother that I was with, my hero, who on a summer day, in July, standing next to him after we tried to walk across Atlantic Avenue in Brooklyn, New York, got the back of his head blown off, and I was covered with his brain matter, right? I'm 17 years old, I'm with my hero, and I'm like, man, the world is great. And then all of a sudden, this is what it is? This is what it looks like? And at my brother's wake, I was introduced to a match head size powder that took me from suicidal, of which I had a plan for that night, took me from suicidal to everything's going to be okay. The problem with that is that it's really not a good coping mechanism. And that's what I used for a lot of years. But understand that people use drugs for a lot of different reasons. And until we get to the underlying issues around that, we're not going to make much of a difference, folks. We're not going to make much of a difference. And so when Nancy said drugs don't work, I'm here to tell you, depending on how you get your drugs, how you use your drugs, your socioeconomic status, and the color of your skin are going to dictate how you get and receive services. That has to change. Everything that's going on in this country right now, the haves are going to have more and the have-nots are going to have nots. It's just the way it's going, folks. This is going to get more intense. And the way that you numb that stuff out is what we're seeing. People are going to turn more and more to narcotics to numb that stuff out. Go ahead. Sorry. The other piece on there was the setting, the context in which people use, the cultural background. Go back one. The cultural background, the demographic, the geographic. Where you use makes a difference. When we talk to people and train them around overdose prevention, we always talk to them about don't use alone. People that use alone die. Talk to your friends that if you're going into a place to get high, to come and check on you. This is stuff that none of us like to talk about and it's uncomfortable. But people are dying. And we need to wrap our heads around it. So if Charles and I go to a drug dealer, hypothetical folks, we go to a drug dealer to buy some heroin, right? Same drug dealer. And we both go there because we both want to get high. But Charles goes to his apartment after copping, and he sits down, he turns on some Cajun music, he goes to the faucet, he gets some clean water, he goes to the drawer, he gets some clean injection equipment because he's got an apartment to keep him in, and he starts to fix up his drug solution. And he ties off, and he gets high. Now understand, there's always potential consequences to any time you use drugs, always, right? But his chances are a little bit lower than me, who goes behind the abandoned building. I pull out my syringes from underneath the dumpster, because that's where I have to keep them. There's a solution there, I think it's water, it's in a water container, and I start to cook up my drugs. And I'm looking over my shoulder to make sure Marvin and the other police officers aren't coming, or that somebody's not jumping me, and I get off. And my potential, because of my being amped up and over alert, and my body's already going, my potential for an overdose are much greater. The drug is going to react differently on me. When we work with people and talk to people, you don't have to get an address, but make sure you're talking to them about being in a safe place. Dead people don't get better. They don't get better. And I'm sick and tired. My whole community is gone. They're gone. Go ahead. Last legislative session, Charles and I submitted some information and some language to Senator Royce West from Dallas-Fort Worth area, who submitted Senate Bill 1462, which allowed for greater access to the life-saving medication, naloxone. This language, this bill, also allowed for a standing order that we thought would be signed by the Substance Use Division at HHSC. Their medical director would sign a standing order so that citizens of the state of Texas wouldn't have to go into their private physician, get a prescription, and then go to the pharmacy. So when you write a standing order, similar to the flu shot, you just go into the pharmacy, right? You don't have to go to your physician. You get this medication. So anybody in this room can go into the pharmacy and say, I have a family member that's on opioids. She just had an operation. I would like to have this medication on hand in case there's a negative event. And they will give it to you. They'll sell it to you. So that allowed for greater access that way. Excuse me, I'm losing my voice. Third-party prescription, think EpiPen to some degree, right? I get prescription, I give it to Charles, Charles gives it to Bernie, Bernie administers it on Marv, right? It's people that get naloxone are not going to administer this medication on themselves, right? So somebody else is going to have to administer on it. This allows for that to happen, and it's completely legal to do that. Go ahead. Opioids sit on the opioid receptor, not only in the brain, but all over the body, and they make your body feel euphoric. Go ahead. All parts of the body, right? The immune system, the liver, the lungs, the brain. Opioids affect lots of parts of the body. So on the flip side of that, when there's negative stuff going on around opioids, if any of these are compromised, it also affects the ability to fight off an overdose. Go ahead. But opioids make you sedated, right? Sleepy, in the middle of the day, things like that. But the long-term opioid use also causes depression oftentimes. It's a double-edged sword, folks. Makes you feel great, makes you feel not so great. But what we see is that people are using opioids at a greater level, even in the midst of us reducing some of these prescriptions. We're starting to see prescription fatalities decrease. which is all well and good, but now we're seeing illicit fatalities go up, okay? So when we come back from a break, Charles is going to talk about where these drugs are coming from, how and who is at risk for overdoses, right? And how to administer this really simple medication. The meat and potatoes of this are after the break. Any questions so far or comments? My job is to pee people off, so.
We're talking about this specific type of drug, but I think that in the conversation that people have, they lump all drugs together, including marijuana, and then there's a lot of issues of whether what's worse than something else. So to a parent or someone, or they'll say maybe marijuana is a gateway to all of this other. What do you say?
What do I say about marijuana being a gateway drug? I think milk is probably more of a gateway drug. I mean, I'm being facetious, but, you know, so we were asked to come here and talk about the opioid crisis, so we'll kind of stick to that. But I will tell you that the vast majority of people that experiment with marijuana never go on to the other drugs. Now, people that end up using heroin, did they start out with marijuana? Probably. But there's probably a little bit more to it than just the drug itself, right? There's a whole lot of dynamics go into drugs. A whole lot of dynamics. What we're going to do is take a 10-minute break, and I really encourage people to come back and so that Charles can get moving on the recognized, respond, and evaluate this.
For today, I'm going to make a change in the restroom assignment. We have restrooms on both sides to the back, but I'm going to request that the men use this section over here, use both the ladies and the men. And ladies, if you would use these two over here, and also if you go around the corner to the left, there's a nursery, and inside that nursery there are some more facilities. So ladies, this direction, men, this direction. But 9.5 minutes.
So 10-minute break, folks.
How do you put this on pause?
This on pause. I can stop it, but I don't know if we can pause it. I guess we can stop it and we can worry about